Hello guys, in this video we'll try to go through the most 30 highest concepts in the cardiovascular system for step 1. We will also try to give somehow a hint about each one of these informations and also how they can ask us about these informations itself. Okay, so let's start. So the first concept is that, and this is something that you will always love to ask about, is atrial septal defect. And they will always tell you a patient is having a murmur, and this murmur is having fixed splitting of S2. And then they will ask you what would be your diagnosis, and the answer is very easy: atrial septal defect. Now they can ask you an additional informations. They can tell you what's the problem in atrial septal defect, and the answer is the problem is in the ostium secundum. Okay. Now atrial septal defect can also happen in Down syndrome. So if you see in the question that this person is having Down syndrome, then there is a probability that he is having atrial septal defect, but this time it would be a problem in the ostium primum. Okay. Now, what is a fixed splitting? It's when the A2 and P2 split from each other, and they are fixed, meaning they don't change during either inspiration or expiration. Okay. Now, the second high-yield concept is that pericarditis will always cause friction rub during chest examination. And this is extremely important because they will tell you, for example, a person is having upper respiratory tract infection, and after 1 week he is presenting with fever, friction rub, pain that's relieved in the praying position or when he is lying forward. And then they will ask you what would be the diagnosis, and the answer is pericarditis. Now they can ask you what's the cause of this pericarditis, and the answer is usually either a viral infection or an idiopathic. Okay. Now, something also high yield about pericarditis is that it can cause diffuse ST elevation, meaning that you will usually see ST elevation in most of the leads in the ECG, and this is different from myocardial infarction, because when myocardial infarction causes ST elevation, it's usually in the leads responding to the artery that has been occluded. So, for example, if it's in the left anterior descending, you will see it from V1 to V4, things like that. So just keep an eye open when you see an ST elevation, that in your differential diagnosis it can be pericarditis. So look at all the leads. If you see it diffusely like that, so for example it's in lead 1, lead AVL and lead V1, it cannot be an artery here, because if it's an artery it would be anatomical leads to this artery. So if you see it diffusely like that, it's usually pericarditis. Okay. Now another thing is that they will ask about the difference between fibrinous pericarditis and autoimmune pericarditis. And these two subtypes are usually subtypes of pericarditis that can happen after myocardial infarction. Now the difference is very easy. Fibrinous pericarditis is the one that happens 2 days after myocardial infarction, when the neutrophils tries to arrive in the heart. So they can invade the pericardium and can cause inflammation, and this would be called fibrinous pericarditis or neutrophilic pericarditis. On the other hand, autoimmune pericarditis will happen the months after myocardial infarction, which is some kind of manifestation of a disease or a syndrome called Dressler syndrome. Okay, and the reason for it is autoimmunity, and it has nothing to do with neutrophils. So the most important differentiation is the timeline, if this makes sense. Now the third or the fourth concept is that whenever you hear machinery like murmur, you would know it's patent ductus arteriosus. And machinery like murmur means it has this machinery sound that happens in systole and diastole. And this makes sense, because patent ductus arteriosus is usually an opening between the artery, the aorta, and the veins, the pulmonary arteries, right? Or the artery and the aorta and the pulmonary artery. So when you hear a murmur, this murmur will always be continuous because it looks like a fistula. When you usually hear a murmur between a fistula, between two arteries, this murmur will usually also be kinda continuous because it's not related to the heart. So it's not related to systole or not related to diastole, if this makes sense. Now, one of the most famous causes of patent ductus arteriosus is rubella. And rubella can also cause cataract and sensorineural deafness. okay? So you can keep an eye open in a child that his mother didn't receive prenatal care, and he's having cataract, and he's having a machinery-like murmur. This is usually rubella, okay? Now, the other concept, or the fifth concept, is rheumatic fever. You need to know it's a type 2 hypersensitivity that happens after strep infection. Because a strep infection can cause two things. It can cause either rheumatic fever, which is a type 2 hypersensitivity reaction, or it can cause post-streptococcal glomerulonephritis, which is usually a type 3 hypersensitivity reaction from complements, okay? Now, the reason rheumatic fever happens is that our body mix up the tissues of the strep with the tissues of the cardiac molecules, or the cardiac tissues, because the cardiac tissue has something called the M protein, which looks like the proteins found in strep. So the antibodies will try to attack the strep, but they will somehow attack the heart. They can also attack the brain, can cause chorea. They can attack the joints and can cause arthritis, okay? And this is here is the Jones criteria to diagnose rheumatic fever, the J for joint arthritis and arthralgia, the heart here for cardiac manifestations. It can cause pericarditis, myocarditis, and the endocarditis. And when it affects the three layers of the heart, this is called the pancarditis. The N for subcutaneous nodules, the E for erythema marginatum. Erythema means redness. Marginatum means in the margins. So it's a rash that has a redness in its margin. Somehow it looks like tinea, okay? And the S for Sydenham chorea, which is abnormal movements that will happen in this child, okay? Now the treatment is penicillin. The prophylaxis is also penicillin. It's rare in developed country. They will usually tell you that this person is immigrant, okay? The other thing, or the sixth high-yield concept, is infective endocarditis. And what they usually ask about it is each bacteria and how it can happen and how it can affect the heart. So Staph aureus can cause acute endocarditis. It happens in IV drug user, and it affects the tricuspid valve. Candida can also cause the same manifestations. And the reason they happen in the tricuspid valve, because an IV drug user will usually inject the drug in the veins. So it will somehow return through the anatomical location in the right atria. So the first valve it will somehow face would be the tricuspid valve, if this makes sense, okay? Now, another important thing is that it can cause acute endocarditis, meaning it can affect normal and healthy valves. It doesn't need the valve to be damaged, okay? And this is the thing about the staph and the candida itself. Now, they can also happen through anything that's injected in the veins. For example, a catheter, central venous catheter, right? So it's not only confined to an IV drug user. The next bacteria, which is the most common bacteria that can cause endocarditis, is Streptococcal viridans, and it usually happens after tooth extraction, okay? And it will cause subacute endocarditis. Now, sometimes they will ask you how it attached to the endocardium through dextrans, something called dextrans. It will attach to the damaged heart valves. Usually, it's damaged heart valves through its dextrans, and it will bind to the fibrin in the heart valves, okay? The third bacteria is Streptococcal agalactia, and this usually gives you suspicion or suspicious for colon cancer. And this is important because how they will ask this question is that they will tell you a person is having an endocarditis from Streptococcal agalactia. Then they will tell you what would be your next step of management if it's step 2. The answer is you would do colonoscopy, right? Because there is a suspicion for colon cancer. Because Streptococcal agalactia is usually resides in the colon. So when you find it in the blood, affecting the blood valves, then you imagine that there is some kind of malignancy that's somehow invading the colon and causing this bacteria to spread, if this makes sense, okay? The fourth bacteria is the Staph epidermidis, and this usually affects the prostatic valves, okay? And the last one is Enterococcus, and this usually happens after urinary tract infection. And don't be confused, because it's called entero, so maybe you would confuse it with a colon cancer, but no, it happens after urinary tract infections, okay? And this is for the 5 bacteria or 6 bacteria here. Now, the 7 most high-yield concept is that you need to know the anatomical locations of each chamber in the heart. you need to know that the left atrium is the most posterior one, and the right ventricle is the most anterior one, and the clinical relation between them. So if the right ventricle is the most anterior, then you know if a person receive a blunt trauma anteriorly, it can affect the right ventricle first. So for example, or even a sharp trauma, maybe a knife, it will affect the right ventricle first. But the left atrium, knowing it's posterior, then you know that it can somehow compress the esophagus, right? So if there is left atrium enlargement, it can compress the esophagus and it can cause dysphagia. The other way around, if there is esophageal problem, maybe esophageal cancer, somehow it can compress the left atrium, okay? Another important thing is that because the left atrium is posterior, then we can visualize the mitral valve, which is between the left atrium and the left ventricle, through something called the transesophageal echocardiogram, okay? And this is helpful in diagnosing some kind of endocarditis, okay? So just know these locations here. Another important locations is the locations of metallic valves on chest X-ray. Now I don't know why you need to know that, but I have seen it asked multiple times on the nbmes. So somehow if you can pull it up and remember the 4 of them, then it would be useful for you. The 9th information is tetralogy of Fallot, and they will ask you usually about what's the most determinant of prognosis of tetralogy of Fallot, and the answer is pulmonary stenosis. So if there is severe pulmonary stenosis, then the tetralogy would be having poor prognosis. If the pulmonary stenosis is mild, it will have better prognostic factors, okay? Another thing is that this is the most common cause of cyanosis in early childhood, and it will usually cause cyanotic spells, and the child will usually squat to increase the afterload to reverse the shunt from right to left to right. And when he squats, usually you will see that cyanosis will disappear, okay? And the answer for that is that squatting will increase the afterload, so it will reverse the shunt. Now, in the chest X-ray, it will appear as boot-shaped like that, and you kind of need to know the appearance of it, okay? Because sometimes they will give you the chest X-ray and they will ask you to identify it, okay? The other high-yield concept, and the 10th one, is that the most common cause of aortic stenosis in old people is degenerative calcification. But in middle-aged persons, 30 or 40, is bicuspid aortic valve. In Turner syndrome, it's also bicuspid aortic valve. And the reason for that is very simple. When we get older, usually degeneration and decalcification happens. So by the time we reach 60 or 70, a good bunch of us will have aortic stenosis. Now it can be asymptomatic, it can be symptomatic, whatever, but many of us will have aortic stenosis when we get older, just because how life goes and how degeneration comes and goes and the calcification happens with time, okay? Now a person that has bicuspid aortic valve, meaning instead of the 3 cusps, he have only 2, will get this aortic stenosis too much earlier than the normal population. Why? Because if the time that's needed to calcify a 3 valves is 60 years, for example, then the time that would be needed to calcify only 2 valves would be 40, would be 30. Does that make sense? So whenever you see an aortic stenosis, crescendo, decrescendo, systolic murmur at the left intercostal space, and they ask you what's the cause of it, always look at the age. If it's an elderly, it's degeneration calcification or degenerative calcification. If it's a middle-aged person, 30, even 40, okay, even 40, it would be bicuspid aortic valve. If it's Turner, so a person with broad chest, short stature, a low hairline posteriorly, then it would be bicuspid aortic valve. Now, if a person is immigrant, maybe it would be rheumatic fever. Rheumatic fever usually affects the mitral valve first, but it can affect the aortic valve. And something that you need to know is that rheumatic fever acutely would cause regurgitation, but chronically would cause stenosis, okay? The next X-ray that's important is notching of the ribs, and this happens in coarctation of the aorta. And the reason it happens is that there will be new blood vessels that will form, and these new blood vessels will form usually to bypass the stenosis that happens in coarctation of the aorta. And these new blood vessels will usually form from the intercostal vessels itself. And when they try to emerge, they will cause this notch here, okay? And the reason they again form is to bypass this stenosed coarctation here. Now, Turner syndrome is one of the famous causes of coarctation of the aorta, okay? And this is something that you need to know. Another cause of congenital abnormalities is lithium. Lithium can cause epistine anomaly, which is usually when the tricuspid valve goes into the right ventricle, and it will cause something called atrialization of the right ventricle, meaning that the right ventricle will have the same tissues as the atria, or the atria will invade the right ventricle. This is called epistine anomaly, and it's a risk factor for Wolff-Parkinson-White syndrome. And remember, in Wolff-Parkinson-White syndrome, you will see a delta wave in the ECG. Delta wave on the ECG. Okay. The other high-yield concept is atherosclerosis. They will usually ask you about what's the most common locations in atherosclerosis. And the most important or the most common location is usually the abdominal aorta, not the coronary arteries. But the second one would be the coronary arteries, okay? And this is important here. Another thing is that they can ask you how atherosclerosis happens. So the first thing is that, and you always have to mention it, is that the first predisposing factor is injury to the blood vessels. And when injury happens, the LDL particles and the macrophage will enter this blood vessel wall. They will start to deposit. The macrophage will eat this LDL. It will cause foamy macrophages. Then the atheroma will happen. At first, you will have fatty streaks if you are 20 or 30 years old. Then you will have this atheroma. Then it will become atherosclerosis, right? And it will begin to be symptomatic if it occludes 70% of the artery itself, okay? Now, the next high-yield concept is arteriolosclerosis, which is sclerosis of the small arteries. And what you need to know is that hyaline arteriolosclerosis, which is in this picture here, you can see that there is a hyalination, which looks like a jelly, right? So there is no cells at all here, okay? And hyaline arteriolosclerosis or arteriolosclerosis happens from diabetes mellitus and also from benign hypertension, okay? Which is hypertension that's less than 180 and doesn't cause end organ damage. But on the other hand, the hyperplastic arteriolosclerosis happens in malignant hypertension. And this is hyperplastic here. You can see there is many cells in the blood vessel wall. And the reason there is many cells because it's called the hyperplastic. So the cells of the blood vessel wall are somehow proliferating, okay? Now the next concept is aortic dissection. And what you need to know about aortic dissection is the most common risk factor for it is hypertension. And this is inversely to abdominal aortic aneurysm, which would usually happens in an old person or old man, and the most common risk factor for it would be smoking, okay? And this makes sense. In aortic dissection, what happens is that you will have a damage to the aorta, and this damage will make the blood goes into the aortic wall and tries to spread to the renal artery, causes stenosis, goes to the heart, can cause tamponade, can cause aortic regurgitation, whatever it causes, right? And because we know that the first thing that happen is damage and tear, we know that high blood pressure is a must or is a requirement for this damage to happen, right? So that's why we know that hypertension is a very important requirement for aortic dissection to happen. But abdominal aortic aneurysm, on the other hand, happens from inflammation of the blood vessel wall, and this inflammation will weaken the wall and make it ballooning, make it looks like balloon, or make it look like less elastic, or make it look like some kind of floppy layer, right? So we know it happens from inflammation. And guess what's the most inflammatory mediator we can take of? It's smoking, okay? So aneurysm happens from inflammation, that's why it's smoking. Dissection happens from damage to the aortic wall, and that's why it's usually hypertension, okay? Now here, this is the dissection itself. Now you can think that this small one is the dissection and the large one is the artery, but it's the inverse. The large lumen is usually the dissection itself, and the small lumen is usually the true artery, okay? Now this one here is dissection in the ascending aorta, and this one is dissection in the descending aorta, okay? The next important information is that the most common cause of death after myocardial infarction is usually arrhythmia, specifically in the first 24 hours. Extremely high yield to know this information, okay? And I have bring it here the table if you need to remember the gross changes, the microscopic changes, and whatever happens, okay? Just to know that the necrosis that happens in the heart is coagulative. Coagulative necrosis is the necrosis that happens in most of the organs, except the brain. The brain will have liquefactive necrosis, and the intestine will have gangrenous necrosis, okay? But most of the other organs will be coagulative necrosis, okay, guys? And yeah, the breast and the pancreatic tissues will usually be fatty necrosis, okay? The other concept is that long QT interval can be a hereditary disease, and they will show you a person who has this hereditary problem. They will tell you he's having family history of it. Then they will ask you what would be the problem, and the answer is the problem is in the potassium channels. And this makes sense. We know that type 3 antiarrhythmic drugs can also cause prolongation in this QT interval, and the type 3 usually inhibit also the potassium channels, right? And the reason for that is that they will delay repolarization. So what will happen is that repolarization will come later, and we know that this T wave here is repolarization. So when it comes later, it will prolong this interval itself between the Q and between the T. So it makes sense that a long QT interval will happen from problem in potassium channels. Now, you need to know that any long QT interval can somehow be predisposed to torsade de bois. And that's why most of the type 3 antiarrhythmic drugs have a high risk for torsade de bois, because they will prolong the QT interval, except only one drug that I will mention later, okay? The next concept is that hypertrophic obstructive cardiomyopathy is an autosomal dominant mutation, and it happens through myosin heavy chain mutation. Now, something I love to remember to differentiate between autosomal dominant and autosomal recessive is that when the problem is a structural problem, so there is a structural problem in the body, then the inheritance is usually autosomal dominant. But if the problem is enzyme problem, then the problem is usually autosomal recessive. So a structural problem will usually be autosomal dominant, but an enzymatic problem will usually be autosomal recessive, okay? Now, HOCM would cause S4, okay, which happens when the heart tries to contract in somehow enlarged ventricle. So it will cause this S4 thing, okay? Or when the left atria tries to contract or eject in an enlarged ventricle and a very narrow chamber, okay? Now, dilated cardiomyopathy, on the other hand, has many causes. Maybe pregnancy, maybe alcohol, okay? A lot of causes. But one of them is mutation in the titin gene and the titin protein, which is this protein here. And this is different from HOCM, which would be myosin heavy chain, okay? Now, dilated cardiomyopathy would cause S3, which usually happens when the atria eject blood in a dilated heart, which will cause some kind of echo sound, okay? Imagine you are going into a very large room and you try to talk. You will hear your echo, right? This echo is the S3 itself, okay? Now, if this is S1, this is S2, S3 will happen after S2 right away, S4 will happen later, before S1, okay? Okay, now the next concept is that cardiac tamponade will cause the Bix triad, and you already know what's the Bix triad. If this is the heart, we know that tamponade is blood around, liquid around the heart. This liquid will prevent the jugular veins to fill into the heart, so it will cause jugular venous distension. It will also prevent the left ventricle to fill into the aorta, so it will cause hypotension, and it will prevent the doctor to hear the sound of the heart, so it will cause muffled heart sounds. This is usually the Bix triad. Now, the other thing is that it can cause pulsus paradoxus. So what is pulsus paradoxus? It's when you inspirate, the blood pressure will decrease by more than 10. So what does it mean? Here's the thing. Usually, when we inspirate, we increase our preload. And usually when we increase the preload, the blood in the right ventricle will increase. Now, when the blood in the right ventricle will increase, it will stretch the free wall, and it will also stretch the septum. Now, when it stretches the septum, it somehow obstructs the left ventricle outflow. So it usually decreases the blood pressure, but as less than 10, because the stretch here is not that strong to obstruct it too much. Now, imagine a person with cardiac tamponade, a person with cardiac tamponade will have a stiffness in the free wall. So when this person tries to inspirate and the right ventricle tries to fill, most of this stretch will happen in the free wall only. So when it happens in the free wall only, it will somehow obstruct the outflow at a greater power. When it obstructs the outflow at a greater power, it will decrease the blood pressure, but more than 10. Okay? Now, pulsus paradoxus can happen from any condition that can affect the heart ability to stretch. For example, COPD. In COPD, the lung is too large because you are reserving a lot of oxygen. There is high residual volume, and it will also prevent the heart to stretch. Okay, so it's not only specific for tamponade. It can happen through any condition that can prevent the heart from filling. Okay. Now, the next information is that myxoma is the most common tumor in adults, and the rhabdomyoma is the most common primary tumor in the heart in children. Okay. Now, of course, the most common tumor in the heart in general is from metastasis, because the heart tumors are usually rare. Okay. Now, myxoma can cause cardiac blob. Prolapse can cause cardiac click or mitral click. Stenosis would cause snap. Okay, and this is something that you need to know to identify them on the exam. If they told you we are hearing a click sound, it's a prolapse. If they told you are hearing a snap sound, it's stenosis. If they told you are hearing a blob, it's myxoma. And myxoma here can somehow obstruct the mitral valve. Okay, that's why you can hear this blob thing. Okay. The next information is nitrates, and what you need to know is that nitrate is contraindicated to give it with sildenafil, because both of them can cause severe hypotension. Okay. Now, the reason this happens is that nitrates activate something called guanyl cyclase, and guanyl cyclase will turn GTP into cyclic GMP, and the cyclic GMP would cause a smooth muscle relaxation, which is vasodilation. Okay, which will cause vasodilation. Okay. Now, on the other hand, sildenafil inhibits something called the phosphodiesterase, which is usually the enzyme that get rid of the cyclic GMP thing. Okay. Now, imagine you are giving a drug that inhibits the enzymes that get rid of cyclic GMP, and you are giving another drug that increases the formation of the cyclic GMP. Then you will have greater amount of the cyclic GMP. Then you will have greater power of smooth muscle relaxation. Then you will have very high vasodilation, which can cause extremely low blood pressure, which can cause syncope. So never give nitrates to a person that's taking sildenafil. Okay. Now, the reason they ask you about it is that they will ask you about the pathophysiology, which is increasing in cyclic GMP. And any drug in general, as a rule of thumb, any drug that can cause vasodilation, it usually causes vasodilation from cyclic GMP. Okay, so cyclic GMP is the one that always causes vasodilation. Okay. Now, they will ask you also how nitrate treat angina, and the way it treats angina is by decreasing the preload or the blood coming into the heart, and when it decreases the preload, it will decrease the heart work. Okay, so the heart will work less, so the heart will need less oxygen. It has nothing to do with dilation in the coronary arteries. Yes, it can cause dilation of the coronary arteries, but this is not why we use it for treating angina. We use it for treating angina to decrease the preload itself. Okay. Now, the next concept that we have is that statin is the best lipid lowering drug and it has mortality benefits. And this is the best drug that we use to decrease LDL, but it can also increase the HDL, decrease triglycerides, whatever. Okay. Now, fibrates, on the other hand, is the best one to decrease triglycerides only. And we have niacin, which is the best drug to increase HDL. Okay. Now, the only one that has mortality benefits is the statin. But the statin can cause hepatic toxicity, and it can also cause myopathy. Okay. Fibrate, on the other hand, can cause myopathy, and it can cause gallstones. The way I remember it is by saying fibrates. It's fibers. It's extremely solid, so it can somehow obstruct the gallbladder, and it can cause gallstones. Now, I mentioned something here. I said statin would cause myopathy, and also fibrates would cause myopathy. So take care and don't try to give them with each other, if this makes sense. Okay, because both of them can cause myopathy. Okay. Now, niacin, on the other hand, can increase the HDL, And one of the side effects of niacin, which is vitamin B3, is that it can cause flushing. And the reason it causes flushing is that it will increase prostaglandin and it will cause vasodilation in the face. So blood will go into the face, it will cause flushing and redness. Now, how would you treat this flushing? Give aspirin. Makes sense. If the cause is increase in prostaglandin, give aspirin, which will inhibit the prostaglandin synthesis. Okay? Don't give antihistamine. Give aspirin. Very important. Niacin can also cause hyperglycemia and hyperuricemia. Okay. Now, what are the drugs that has mortality benefits? And you need to know it. Extremely high yields, they always ask about it. Beta blockers, ACE inhibitors, potassium-sparing diuretics, and SGLT2 inhibitor, which is a diabetic drug. All of them can have mortality benefits. Okay. Now, the best one that they will usually ask you about is ACE inhibitor. ACE inhibitor has mortality benefits, and it also decreases cardiac remodeling after myocardial infarction. So cardiac remodeling is something that happens in the heart, and it can cause the heart to hypertrophy and to not cause its function very well. So the way ACE inhibitor do is that it will prevent this remodeling, because remodeling usually happens from increase in the angiotensin, and the ACE inhibitor will inhibit this angiotensin thing, right? So that's why it can decrease remodeling, and that's why it has mortality benefit. Now, it also has mortality benefit for patients with diabetic nephropathy. When you see a person with diabetes and he is having protein in the urine, then you know that he is going through diabetic nephropathy. Then the first step that you do is giving him ACE inhibitors, even if he doesn't have hypertension, okay? Also, renal complications we can treat it by ACE inhibitors, except bilateral renal artery stenosis. Some resources or some studies says that ACE inhibitor can be contraindicated in bilateral renal artery stenosis, not unilateral. We use ACE inhibitors for unilateral, but it's contraindicated in bilateral, okay? Remember that renal artery stenosis will happen in your exam as a Berui. They will tell you a person is having Berui. And this Berui, or this renal artery stenosis can be caused by two conditions. If you see an old man, it's usually caused by atherosclerosis. If you see a person that's middle-aged and it's a female, then it's usually caused by something called fibromuscular dysplasia, okay? The next information is that digoxin can cause yellow vision as a side effect. It can also cause GI symptoms, okay? But sildenafil would cause blue vision. And the way I remember it is that it's the blue bells. So it will cause blue vision, okay? Now, another thing in digoxin, and some students mess it up, is that digoxin can increase the contractility, right? Because it will inhibit the sodium calcium channel or whatever, increase calcium inside the cells, increase the contractility, right? But another thing in digoxin is that it decreases the heart rate, because it increases the vagus nerve, which is the parasympathetics in the heart, okay? And this is some kind of a paradox thing, right? So it increases the contractility, which is the force of the heart, but it decreases the heart rate. It can cause heart block, okay? Now, the way we treat digoxin toxicity is by something called the DG bind or DG fab. And what you need to know also is that hypokalemia can cause digoxin toxicity, but digoxin toxicity can cause hyperkalemia. So hypokalemia can cause digoxin toxicity, but digoxin toxicity would cause hyperkalemia, okay? Okay. Now, the other next high thing is that amiodarone is the least type 3 drug to cause torsades de bois. So this is torsades de bois here, and amiodarone is the least type 3 drug to cause this torsades de bois. But it has a lot of side effects. So, for example, you will see doctors prescribing it. The reason they prescribe it because it's very safe, and it has low affection or low tendency to cause torsades de bois. Because yes, it prolongs the QT interval, but not that much, okay? Or even if it prolongs it, it doesn't have this affinity to cause the severe torsades de bois thing. Now, the way they will ask you about it is that, okay, why don't we use it that much if it has less side effects or less arrhythmia side effects? Because it has another side effects in each other organ. It can cause corneal damage. It can cause hepatotoxicity. It can affect the cytochrome B450. it can cause thyroid damage, either hypothyroidism or hyperthyroidism. It's called iode. It's made of iode, so it's used in the thyroid. It can cause brain damage. It can cause lung fibrosis. Remember the drugs that can cause pulmonary fibrosis. We have Amiodarone. We have methotrexate. We have busulfan, which is one of the chemotherapeutic drugs, okay? So these are the things about Amiodarone itself. Verapamil, on the other hand, is a type 4 antiarrhythmic drug, and it can cause constipation and gingival hyperplasia. Now remember the drugs that can cause gingival hyperplasia. We have phenytoin, right? We have cyclosporin, and the other one here is Verapamil, okay? Which is a calcium channel blocker. It's a non-dihydropyridine calcium channel blocker, okay? The other thing is hydralazine. It can cause drug-induced lupus, brokinamide also, isoniazid also, and alpha-methyl dopa. And the way they ask about drug-induced lupus is that they will ask you which antibodies you would see. And the answer is that you would see antihistone antibodies, okay? You would not see ever some kind of anti-double-stranded DNA antibodies. You would usually see antihistone antibodies, okay? Because the anti-double-stranded is the one that happens in the OG lupus, not the one that happens in drug-induced lupus, okay? Okay. Now, our last information here is that atrial fibrillation is usually a problem around the pulmonary vein ostia in the left atrium. But atrial flutter is a problem around the tricuspid annulus, okay? So if this is the heart here, atrial fibrillation will usually arise from different or abnormal electrical activity around the pulmonary vein ostia, okay? And remember, we have 4 pulmonary veins. But atrial flutter will happen from problems around the tricuspid annulus, okay? This is important because they will tell you how to treat these conditions surgically. So the answer is that if you have an atrial fibrillation, you would usually cause cauterization or cauterize the pulmonary vein ostia. But if you have atrial flutter, you would cauterize the tricuspid annulus, okay? So you would inhibit the electrical activity by literally inducing a necrosis in these specific locations, okay? Now atrial fibrillation here would cause tooth appearance, right? Or sawtooth appearance, but atrial flutter would just be irregular heart with no B wave at all, okay, guys? And that's it. I think this is the most 30 high yield information if you just need to review the cardiovascular too fast and figure out what's the most things that you need to be aware of. And that's it, and thank you guys for watching. Bye bye.